Okay. All right.
It's up. We can
It's
see it
up,
now.
right? Okay.
Yeah.
So I would like first to thank to be part of this interesting panel and part of this activity. And with that, I will like to tell you that I have no financial gains from what I'm about to tell you. So what is the role of ICP monitoring in children? Well, as you know, there has been a number of studies that have led to the guidelines for the management of pediatric severe head injury. And that based on the data that has been recollected, the degree of certainty for recommendation of ICP monitoring and CSF management has come out as class 3 evidence. We know that it does improve the overall outcome of traumatic brain injury. And of course, in every neurosurgeon's mind, the fact that if we know what is going on pressure-wise within the skull, then things should be more controlled, right? However, there are many confounding factors of why is it that we're still dealing with class 3 evidence, and that's what I want to talk about. Of course, over the years, our environment for treating children with severe head injury has become more and more complex, not only within the hospital, but also the boundaries of the hospital. Pre-hospital care is getting better and better in many places around the world. But there are so many confounding factors that in order to analyze one single thing that we do is not that easy. We know, of course, that if you plot morbidity and mortality in a time lapse, we have two phases: the primary injury with either hematomas, contusions, or diffuse injury, which will lead to increase of the intracerebral pressure, and that will give rise to either hypoxia or ischemia or hypotension as a result of associated injuries. And these will lead to secondary insults, which will produce on their own all of these mechanisms. Tony has spoken a little bit about this. I will not go deeply into this because this would be just a single talk by it, but there are so many new things that we're learning that happens at the cellular and molecular level that does not only affect the immediate, but the long-term outcome of these patients. And of course, we're now trying to understand how we can do our intervention in all of these phases. So what are the simultaneous factors that confound ICP monitoring? Well, better per-hospital care. Some of these patients are either intubated at the site of the injury, or sometimes in order for them to be transported to a class 3 trauma hospital center, they're intubated prophylactically, in order to make sure that the transport is going to go more smoothly. Also, there's aggressive treatment of hypolemia and hypotension. Some kids are even given osmolar therapies even before they reach the hospital. And of course, CT imaging is becoming more and more widespread, so we're able to know which kids should go well. And of course, in the long run, some other things such as enteral and parenteral nutrition can be of impact. What we do know is that the sustained elevation of ICP is a key pathophysiological variable in the occurrence of secondary brain injury following the traumatic brain injury. Now, let me show you this image. Would you agree that this child needs ICP monitoring if the child shows up to the emergency room at your hospital center with a GCS of 5? I think most of you would agree that yes, it does need ICP monitoring. Well, it becomes creepy or difficult to make the decision when that child shows up with the same imaging at GCS3. And everybody would, in some centers, they would say, yes, we'll still put an ICP monitor because, we need to document legally what is going on in a center. But in some environments where you're constrained by economic factors and you don't have fibers for everyone, you might say, this is GCS3, the image looks really compelling that this child would not recover. I will not do it. So these are the things that come into play. Of course, when we see images like this, when you have infarcts in the basal ganglia because of damage, then probably the decision not to monitor ICP would be more easy and more straightforward. But of course, we know that there is a variation in therapy and outcomes for ICP monitoring. And the most interesting thing is that we should keep in mind that hypotension and hypoxemia, as shown in the traumatic data coma bank, are the main drivers for bad outcomes. So you should avoid at all means these two factors. And we know that after traumatic brain injury, intracranial hypertension and systemic hypertension is very bad. So that's what you should pursue. And of course, you can, there's also a discussion, and this would be a completely whole different talk if we want to decide if you want to go via ICP or CPP, right? But we know that even if you go by both ways, the outcome will be better. What is the problem with studies regarding ICP and their outcomes? Well, sometimes there's a small sample size, there's inadequate measurement of the severity, the codes come in different formats. The mortality is the only outcome in many of these studies, and there is a lack of uniformity whenever you cluster patients by hospital. But look, this is very interesting. Why is it that only less than 60% of patients with traumatic brain injury are being monitored in the UK, and then in the US, in some places, it does not even reach 30%. And in North Carolina, in a study done in children less than 2 years, less than 1/3 only went on to receive ICP monitoring. And what are the main reasons for not placing an ICP monitor? Well, it seems that nowadays we find more adolescents that come in either in post-ictal state or are intoxicated, and then it's hard to make a decision by those who are looking at the patients. Some of the patients that initially were classified as a lower GCS score actually do improve on their way to the hospital. Some other surgeons will consider that, yes, this patient has a hematoma, but I'm pretty sure that if I'm very straightforward and drain the hematoma, the child will recover without any major issues. Therefore, I don't need to monitor ICP, right? Because it looks like he's going to do fine because the time of the injury and the drainage are really close. Sometimes, some of the patient like this, you would decide, no, this is not worth ICP monitoring. I will just take the hematoma out. But sometimes on some of the patients, like I stated before, there's devastating image that some surgeons might choose not to waste an ICP fiber in an economically constrained. Or sometimes you have a moribund patient. Sometimes you're dealing with infants and you're not sure whether you're going to place the fiber and whether that's going to be useful. And this is something that sometimes is a widespread thinking. And of course, in many systems, it's not documented if you are placing ICP monitoring. So that makes it hard. So when you take patients as a unit of measure, hospital as a unit of measure, and you try to associate, we always end up with class 3 recommendations. But I think the main questions are the kids with severe traumatic brain injury at the risk of intracranial hypertension. Well, we know that diffuse cerebral swelling in a CAT scan is 75 specific for the presence of intracranial hypertension, and that 1/3 of the kids who had an initial ICP measurement greater than 20 at some point will require intensive care and measures in order to lower that, and that it would be more prevalent to have spontaneous motor function is not demonstrated in kids who have raised compared to those who doesn't. So hold on, let me move from here. So the data that we have obtained, are they useful in management children with severe traumatic brain injuries? So there are 15 studies that involve almost 900 patients that associated intracranial hypertension with poor neurological outcome or death. And from one of these studies, this is a very interesting paper, we do know that, yes, we know that the patients who go on to be monitored, of course, we're doing a lot more of things to them, and their hospital stay is really longer. But the confounding factor is that sometimes we cannot demonstrate a significant difference in between those who were monitored and those who did not. So in this study that was published in JAMA Pediatrics, we found that when a propensity-weighted logistic regression model was done in almost 3,000 children, we were not able to tell a significant difference in the functional survival between the groups. And there was no significant association also between monitoring and hospital mortality. And we do know that those kids who have ICP monitoring probably have greater treatment intensity than those patients where we're flying blindfolded. So When we look at all these variables and what is it that we do, of course, kids that are monitored do go on to receive more intensive care. And I think one of the most interesting things is that once you put that monitoring, then it needs to be vigilated. So in the interesting of time, I think that we know that within the predictors of intracranial hypertension in children, roughly 85% of kids with ICP monitoring receive therapy to treat intracranial hypertension. And of course, the significant predictors is that if the patient had a hypoxia prior to arrival to ICU, they're female sex or have a higher injury severity score, of course, they're more prone to have greater injury. So I think the recommendations here is that the decision to insert and use any monitoring device depends on the understanding of the data and the information derived from that monitor. I remember the time, and we discussed this with Tony Figaggi when we were looking at interstitial oxygen, and the numbers were just too many, and not everybody understood those numbers. And sometimes in some centers, people even didn't want to look at the numbers because the interventions were so many at such short time frames that some people chose just to look at the average after a few couple of hours and not be doing like minute-to-minute intervention. But I think IC monitoring is here to stay. We need to do randomized. I think we need to pull data from many centers across the globe to prove that the best way to know is the more data that we have, we will understand more the outcomes and the factors that influence the final outcomes of kids with severe head injury. And with that, I would like to thank every one of you.
Thank you very much for that great talk. I know that we have a discussion at this time. I'm just wondering, Dr. Salman, do we have time for that, or should we keep moving?
Sure, we can have short discussion.
Sounds good. I really enjoyed all the talks so far, and I really appreciate the speakers' flexibility just in terms of being here. Just looking at some of the questions through the chat, one thing that came up just in general, ICP monitoring. I know you touched on this, Dr. Caceres, but also interested in everyone else's opinion too. But does ICP monitoring improve long-term outcomes in your opinion for pediatric TBI? Or is it just guiding short-term treatments, do you think?
Well, I think there is a little bit of the patients that we choose not to monitor probably have worse outcomes, and some of them die, right? So we cannot tell what the functional outcome of those patients was eventually going to be because, like I said, the endpoint for most of these is mortality, right? Once the patient is dead, you cannot measure outcomes. So from those which you place the monitor and you treat it, of course, some of these kids, nevertheless, even if you rescue them, will have bad outcomes. But I think the main thing is that if you do not monitor the numbers, those children are more prone to suffer, hypoxia, more injury to the brain. And I think where all this data is really interesting. I would like to ask Tony what his take is, on the current, when you associate ICP monitoring with LICOX, what is his final say? Because this has been an ongoing discussion from, I guess, more than 20 years, right, Tony?
Sure. I mean, I use both. So the more information that I have about the underlying physiology, the better I think my decisions are about how to treat it. So, so as I said, I think intracranial pressure is always my first go-to, but I just think we have capacity to have a little bit more information, because especially in children, because sometimes it's hyperemia, and I'll tolerate an ICP of kind of 20, 21, 22 in a completely different, with a completely different approach than in a patient who's got a brain oxygenation of 10 millimeters of mercury with the same intracranial pressure. And as I said, the changes in CO2 and the changes in blood pressure have very variable association, very variable effects on both intracranial pressure and brain oxygenation. So for me, I think it just gives me that little bit of extra edge in terms of trying to make a little bit more of an informed decision. And then if I can just piggyback on one of those questions about whether ICP monitoring changes outcome. Again, like I said in my lecture, the ICP monitor itself can't do anything. It's all about what we do in response to that number. If we do silly things, then it's not going to benefit patients, it's going to harm them. So that's the first thing. And one of the problems with the literature, and you see this a little bit more in the US, is that there are several publications that take these large trauma databases. I think there's called the TQIP database, Eric, in the US, and often general surgeons publish these articles. And then they take everybody and then they look at those who had ICP monitors and those who didn't have ICP monitors. And very often the ones who did have ICP monitors are a little bit worse off. But the problem is there's no way in that database that they can control for the reason that people put ICP monitors in. And almost invariably, those are more severely injured patients. And the severity of the injuries just doesn't come through in the database. And I really do wish that journals would stop publishing it because it's so incredibly misleading. So that's my rant for the day.
I would echo everything that both Dr. Caceres and Dr. Fagaji said. Tony, when I look at those database trials that you're talking about, I mean, what the first thing that comes to mind is garbage in, garbage out. And to echo what I think Dr. Caceres was speaking about, there's just a huge selection bias in those databases, which kind of invalidates the results. The other thing that I would say that we've used, we don't use Lycox in our ICU, but we have been using PRX after reading, especially some of Dr. Fagaji's manuscripts on that. And we found that to be quite effective in terms of trying to manage CPP for optimal outcome.
Hi, Tony and Adrian. I think the brain monitoring for ICP depends also from the age. Could you talk a little about the monitoring, the need and method of monitoring by children in the first 2 years of age?
That's even trickier, Arthur, because everybody will tell you that, of course, there are certain things. Well, number one is that I think as we're aging and getting more data, we realize that the old cookbook recipes for intracranial pressure and metabolism is just not the reality. Those data were very valuable, but not always applicable, because sometimes we see kids with a shunt malfunction who have ICP of 60 and are running around like nothing. Of course, trauma is a completely different deal, but of course we still do not know what the adequate CPP is for kids 2 and younger, right? We try to imply that from adult numbers, but it's really hard to tell, especially those kids under 2. And of course, kids who have been subjected to non-traumatic injury, shaken baby syndrome, those are different from high-speed injury or, the other classes of falls and so on. It's very complex to start dividing all these categories and analyzing each of them. And that's why we need to do more collaborative studies.
Maybe if I can add a comment, if it comes to the costs and limited resources, maybe also the role of an EVD should be defined, because it's one of the cheapest way to measure and also to treat ICP.
Yes, at least in our center, most of the time they go hand in hand. But I do not know of a study which has looked, because sometimes, especially in kids who have severe brain edema, some surgeons will hesitate to put an EVD, because they fear that they will not hit small ventricles, or that sometimes They will enter the ventricle, you squirt a little bit of CSF, and it's done. In our center, we believe that every single drop that comes out is at least one single drop that you have to deal with. But this is not everybody's opinion. You know, old school, it's impressive how it models the conduct of so many surgeons around the globe. Some people are very hesitant to put an EVD, right? Especially with edema.
Thank you so much for the discussion and for everyone's input. I just wanted to ask Dr. Blount is here as well. If he wanted to make just a few comments, he asked before we move on to the interview very quickly.
I just wanted on behalf of ISPN Education to thank the speakers this morning for their flexibility. Hassan, you've already done some of that, but on me was a confusion on our day, and we were originally thinking we were talking on Sunday, and it was earlier in this week that we realized the error. And I want to specifically call out Adrian, my partner Arthur, and Tony for their remarkable flexibility, dedication, contribution this morning. So thank you for your flexibility. For the audience, I want them to realize how accomplished these leaders are in ISPN, and that we're very grateful to have them here to participate in this. And finally, that ISPN very much values the collaboration with WFNS to participate in pediatric activities, and congratulations to the organizers and moderators for this very good session. So thank you on behalf of ISPN.